Spotlighting Hawaii's leaders.
We want to bring in Governor David E.
Good morning, Mr. Mayor.
Lieutenant Governor, good morning. Thanks so much for joining us. Mayor Derek Kawakami.
Thank you so much, Senator, for being here.
Spotlighting the issues.
Where is the virus right now in our community?
How much is this overall going to cost the state?
How are you responding to the community's concerns? Talk about the level of citations that you guys are writing.
Spotlight Hawaii with Yanji Denise and Ryan Kalei Suji on the digital platforms of the Honolulu Star-Advertiser. This episode of Spotlight Hawaii is brought to you by Chaminade University.
Well, good morning and welcome to Spotlight Hawaii on this Aloha Friday. I'm Yanji Denise. My co-host Ryan Kalei Suji is off this morning, but of course we press on. We have a great guest today. He is the head of two very important city departments, EMS and Ocean Safety. So we're joined this morning by Dr. Jim Ireland. Thank you so much for being here this morning.
Good morning. Thank you, Yanji.
I want to get right to the numbers that we've seen this morning. Again, we're trending in the right direction when it does come to COVID. 156 cases, unfortunately 5 deaths, but still those numbers are a vast improvement from where we have been just weeks ago. From where your agency sits, how are things looking?
From the standpoint of COVID, looking really good, but we are still picking up patients, often unvaccinated, sometimes very, very ill. But the numbers compared to just a month ago are drastically better. Now, we're still very busy because people are out and about, the tourists are back, people are doing recreational activities that have, some element of danger. And so while the COVID cases are way down, that's great news. EMS and Ocean Safety as well, their call volume is up, surf is up, rescues are up. So they're actually quite busy.
And let's talk a little bit about what EMS has experienced throughout the pandemic. We know that this agency, I believe there are 19 rigs. Correct me if I'm wrong. There may be 20 now. Are there 19 or 20?
21.
21. Fantastic. That's more than I thought we had, but still 21 for the entire city and county of Honolulu is it's a pretty stressed agency. And I know that these paramedics work so hard and they have been through so much in the last 19 to 20 months. How are they doing and how is burnout for your staff? Because we hear a lot about that in the medical profession when it comes to nurses and physicians assistants and doctors. How is that for the paramedics that you manage?
First of all, the paramedics, the EMTs, our dispatchers, and all our lifeguards in Ocean Safety, and medical personnel and health services, they're all great and they work very hard and really serve the public well. But when it comes to EMS, COVID has been a roller coaster. In the beginning, we really didn't have any cases, but we heard about cases in the mainland. There was a fear. There was people getting infected, healthcare providers and paramedics, and dying in the mainland before the vaccine. So there was initially a lot of fear, but not a lot of calls. Then we had kind of our first surge. Everybody had their PPE. We only had one person get infected, and he may not have even gotten infected at work initially in the first surge. So we had this then now confidence that the PPE worked, the training worked, but it was really busy. Then after that first surge, there was this lull, and we didn't have tourists here. People were largely staying at home. And so our call volume was actually down 20%. And I'd say, people got a little rest, and that was kind of the calm before the storm, because then of course, the second peak came with the Delta variant, and we were super busy again. And then people were back, tourists were back, people were recreating, and the call volume that was non-COVID was high as well. And that was kind of the 1-2 punch of COVID for EMS. Unlike the nurses, we did not get federal reinforcements from FEMA coming in to help. We really just had to rely on our own personnel. And this disaster, and it was a disaster, was different than our typical disaster. So for instance, if a hurricane was coming or something, we'd have a short amount of time to prepare. We'd ask all our personnel to work very, very hard, but there'd be an end to it. It'd be over in a week, it'd be over in 2 weeks, or at the worst, a month. And then you kind of go back to normal. This has been, and I'm losing track of time, but 20 months maybe or more. So there's no end, but now I can see an end, and we can see an end, but our call volume is still very high. So yes, stressed, but very professional. People go into EMS because they really enjoy helping people and they want to do this line of work. But there's a limit to everything. And so I just really commend all our personnel and what they've done during this pandemic. And the lower call volume as far as COVID cases is reassuring for us.
One of the things that we talked about when Mayor Blangiardi was on earlier this week was the CORE program. We know that that's officially launching today, and your agency is very much involved with that. For viewers who aren't familiar with this is the city's new pilot program to try to address homelessness in a new way. Rather than dispatch police officers or paramedics on their own, they would now do it under this new umbrella of a program, which also involves social workers, and hopefully not shuttling these folks to jail, but actually getting them the care that they need. Tell us about this program and sort of how your agency interacts with it.
CORE was modeled after some other programs that were on the mainland called Cahoots, and there's some other names out of Oregon and Denver, where people having a mental health or medical emergency aren't automatically referred to the police or automatically referred to 911 ambulances and taken to the ER. Because what happens a lot of times is someone who's homeless, who may have a foot wound, calls 911 or somebody calls for them, and they're taken to the ER. ER treats them and discharges them, and they walk out in front of the ER and just lay back on the sidewalk. And so it's this cycle of street, ambulance, ER, street, and then it repeats itself. And in EMS, traditional EMS, when someone goes to the ER, that's the end of the relationship. We hand them off to the ER staff, we wish them well, and then we go on the next call. Well, this is a little different, and CORE stands for Crisis Outreach, Response, and Engagement. And it's going to be EMTs, similar to the ones who work on the ambulances, maybe at some point later, paramedics as well, coupled with community health workers that are trained often through a program through KCC, as well as other healthcare providers such as social workers and physicians. And we're still kind of organizing the network of how this is going to be deployed, but it did start yesterday. And we want to interrupt that cycle. And I think the key is if the patient doesn't need to go to the ER, we want to take them to a more appropriate level of care, such as a clinic or a detox or a homeless shelter. And then we want to have a case management aspect of this, where just because our ambulance takes them to the ER, and CORE is right now using refurbished city ambulances that are no longer doing the 911 calls, but still licensed ambulances. After their ER visit, we don't want to just say goodbye. We want to say, let us know, and we want the ER to let us know what's happening after their ER visit. And so we can engage them again, help them get to a shelter, help them get referred into the existing care network that's already there. We don't want to duplicate services that are already present in the community. We want to act more as connectors to make sure people can get to a homeless shelter or get into an addiction recovery treatment center, more close followed psychiatric services. So there's a front end where we're actually responding and meeting people on the streets, but then there's a back end as well, which is more case management and connecting. So people aren't allowed to fall through the cracks and just go right back to the sidewalk where the 911 call was generated.
And I know that you're starting out with 2 rigs and staffing for that. Do you have enough people to staff the services that are being launched right now? And how large do you expect this to grow in the coming months?
Well, we're starting just with literally a handful of staff that were already hired or recently hired within our department. We've interviewed quite a few people. We're in the process of hiring people, but I think ultimately we'll have a staff of about 25, probably 10 EMTs, 10 community health workers, and 5 mix of supervisors and social workers, probably some nurse practitioners, to make this multidisciplinary team that will have expertise in different areas to address homelessness. And what I've talked about in other places and told people is the homeless issue and homelessness and the problem of homelessness is not easy to fix. Otherwise, it would have been fixed already. So this is just a different approach, following patients, following people, connecting people with services to try to do better.
So take me through, I know you had a dry run, if you will, yesterday, and then, like we said, it officially launches today. Take me through what a call would look like and how that would be different. Do police officers still respond? Is it simply this core team? Is there a social worker in the rig? Sort of walk us through what that actually looks like.
So right now when a 911 call is generated and it's of a medical nature, our dispatchers, who are all fantastic, follow a national program called ProQA. It's a nationally recognized program. It asks a series of questions for whatever the complaint is. And they decide based on those questions what needs to respond to that incident. Sometimes it's ambulance without lights and sirens. Sometimes it's ambulance with lights and sirens. Sometimes it's ambulance and police. Sometimes it's ambulance, fire department, and police, depending on what the call is. We're still going to use that ProQA, but if it is a person who happens to be homeless and the call is not life-threatening, it's a minor call, the core team may be dispatched instead of a traditional ambulance, and will get on scene to assess the patient. They'll most likely go without their lights and sirens and assess the patient. Now, if there's any indication in the ProQA questions where the patient could be dangerous or some kind of violence, there's a risk for that, the police will go just like they would on a normal 911 call. We are not going to be going in place of the police. But if it's a social issue, if it's behavioral, and there's no safety concerns, once court gets there, we can tell the police, we got this, you can go on and relieve them so they don't need to stay at the scene. If it's an advanced life support type situation where they need a paramedic ambulance, then the core team can call the paramedic ambulance in for transport to the hospital. But for many, many of these calls that involve homeless with minor complaints, and by minor complaints, sometimes people, when we get there, say, I just am hungry. They actually generate a 911 call for that, or can I get a bottle of water? So these are complaints that are bothering the person, but they don't necessarily need a 911 ambulance, the fire department, and transport to the nearest ER. They need to be addressed in an appropriate, compassionate way, but not in the traditional model that we have now. So once the core team gets there and does the assessment, they may decide the patient doesn't need to go anywhere and just needs some treatment or something addressed right there. But we really don't want to leave people on the streets if that's where they're living. So, at that point, they may bring them to the Punawai rest stop, where we're going to have a partnership with the clinic there, partnership with a nonprofit agency. And once they're at the Punawai clinic, get their mental and medical issues addressed. And then from there, we look then at placing them either at a shelter, transitional housing, perhaps HONU. But the idea is once the call's generated, we don't want them to be right back on the sidewalk in 3 or 4 hours after the engagement. We want them placed somewhere. We know there's going to be challenges. We know there's people who are going to refuse our help, but we feel we have to start somewhere.
There's some questions here from the audience. Heidi wants to know, will there be a focus on drug addiction and mental health? We know that there are limited resources for those facilities. Tell us a little bit about, you talked about some of the responders that would be there that wouldn't be traditional paramedics. I forget the term that you used for these folks that are trained by KCC.
Yeah, that would be the community health workers. We definitely recognize mental health issues and substance use issues, whether it's drugs or alcohol, have a large role in homelessness. And I also recognize there's limitations in these type of services in the community. So one of the things CORE is going to do is we're going to work with providers and give recommendations to the city and the state on increasing those resources if that's where the bottleneck is, because we can rescue as many people as we can off the streets, but if there's nowhere for them to go, we're not going to be successful. So we definitely recognize that, and we're working directly with some of the partners on Oahu to increase those numbers if we can.
Anton Krupke is going to be on here in a few weeks, and so we're going to dive deeper into how this is all being structured from the city's standpoint. But I'm curious to know what you can share with us about cost of this program. Something like this obviously isn't cheap, but it does sound like a worthy investment.
Well, Anton and his group actually were the founders of this, and I didn't mention that earlier, but this was born out of his office, and I and others went to these initial meetings maybe 6 months ago, how CORE should be structured. And through the course of the meetings, when we really identified how much medical and mental health were a part of this solution, that's how I think it ended up really resting with our department. But we are working in very close collaboration with the Mayor's Office of Housing and Homelessness, as well as other nonprofit community partners in the state. And so Anton and I are kind of joined at the hip with this and going to make it succeed. So the cost initially is going to be funded through ARPA, the American Recovery Act. And we're looking at a budget of about $3.5 million for the first year, maybe as much as $5 million. But just to reflect back on what potential savings we're going to have, as part of this, we've done a little research. And last week, we just, as prior to the launch for this, we looked at 5 people who were homeless in downtown Chinatown and 911 calls they personally generated. And 5 of them in the month of September generated 80 ambulance transports to the ER, just 5 people. One of them had 30 alone. One person had 6 ambulance visits in one day, traditional EMS. So you can imagine one person with that usage of ERs and EMS can generate over $1 million in care alone in a year, one person. So, and we just looked at the top 5 just in Chinatown, and it was 80 transports. So when you look at other parts of the island, people, the old kind of politically incorrect name for this was called frequent flyers. That was the nickname, people who called the ambulance every day. There's other names, hyper users. There's different terms for it, but basically it's people who use EMS and 911 in far excess of kind of the rest of the community. And often it is for minor complaints, still things that need to be addressed, but not 911 ER level of care. And we think that we will vastly save more than what this program will cost if it's at even 3.5 to 5 million a year.
We know the ARPA funds are limited. Since this is, in that first year, to $3.5 to $5 million is funded that way. Will this be here for a year and then go away, or will it then have to be funded through the city budget or the state legislature? Where, if we hope to make this permanent, how will that come about, do you think?
Well, the ARPA funds are scheduled to last for 4 years. So I think, barring any changes, we have 4 years of this program, hopefully. Beyond that, you would need potentially congressional earmark, state funding, or it just has to get rolled into the city budget. But one of the things we're going to be very keen on is generating data, and data in how we're saving lives, how we're helping people, how we're getting people housed, but also what kind of money we're saving in diverting people away from ERs and traditional ambulance trips. And my guess is the savings is going to far outweigh the cost. And I think if we can show things like that, it will make people more interested in funding these programs, especially once I think the public and the business people can see tangible differences. Because I told people, we can show numbers, and numbers are good, and data is good. But what I think a lot of times the businesses want to see is somebody not necessarily sleeping in front of their business, 24 hours a day. And people want parks available for children and for sports activities, and not, makeshift tent cities. So I think those are the visual impacts we can make in the community as we help people, as well as, numbers and data and actually what we're doing.
Yeah, I mean, Lily's got a point here. She says, it's just as a comment, thank you for addressing the homeless issue in a different way. It sounds like it will save money, resources, and lives in the long term. I think, we've all lived with this homeless issue for long enough that we know who are the chronically homeless in our own neighborhood. And there are people who we pass on a regular basis. And I know I personally think, wow, why isn't anyone helping that person? Why aren't there more resources? But it goes back to a comment earlier about the mental health issue and the drug addiction issue, and just not having anywhere to sort of take these folks or the resources to get that done. In other cities where they've done this, what kind of success have they seen?
I'm sorry, one more. The other cities, I missed the last part.
In other cities that have employed this, what have you seen in terms of success?
Well, and we have informally consulted with some of those other cities and other experts, and it definitely reduces the burden to police. We want police available for crimes and prevention and public service, and not to get tied up in mental health issues when they don't have to be. It's decreased ambulance usage inappropriately, and it's also with de-escalation techniques used with the mentally ill, sometimes it can divert people from being arrested for non-serious, non-violent crimes. And I think, we have to remember that these are human beings. These are people's brothers and sisters, their parents, their children, and we do really want to help them. I recognize that not everybody will accept help, but I think for the ones who will accept help, I really think we have an opportunity to do a lot of good here.
That's fantastic. I want to talk about a little bit about the employment opportunities involved with this. Tell us a little bit about, who can get hired for this? People who are looking for a job, can they come join the core team? What are the jobs available right now?
Well, we're hiring EMTs. Most of them have been trained through Kapiolani Community College, and these are the same workforce that wants to work in EMS, and we're hiring in EMS. Like I mentioned, the Kapiolani Community College also has a community health worker program. I believe it's 200 hours. We've talked to many of their graduates, and we've interviewed many of their graduates. We're still looking for some social workers and nurse practitioners, and just people in general who've had experience with mental health, social work, even if they're not a licensed psychologist or psychiatrist, because first of all, not everybody can work with the homeless and the mentally ill. There takes a certain level of compassion and commitment, because sometimes it is very challenging. But people who have had these types of positions in the past, case management, working in group homes, and if they're interested in working with the city, we'd love to talk to them. It is unfortunately contracted positions because we don't have permanent funding now, but I think it's an opportunity to do a lot of good. And again, we've putting together a diverse team. Some of the people that will be joining us have experienced homelessness in the past, and there's this concept of shared experience. And if you've been there, you really can relate to what some people are going through who may be living out of their car, living in a park.
It all sounds fantastic, and like I said, after we've all experienced this situation in our community, to have a new way to address it is definitely giving a lot of people a lot of hope. I want to ask you about your other role. I know that you have a lot of jobs, and the other one is to be the director of ocean safety. There was there have been some strains on that department as well in terms of staffing. How are staffing levels with that agency right now? Do you have enough lifeguards for all the beaches?
I wish they were better, but they're adequate right now. But we definitely need to get a new recruit class in the first part of 2022 to hire some more lifeguards. This ordinance was changed where we have now expanded hours earlier in the morning and later in the afternoon. And that was always planned as a phased approach. We weren't going to have that completely covered from day one, but we have expanded the hours of the lieutenants, the mobile responders, as well as the rescue skis. Not the towers yet, but like many other city agencies with injuries, vacation, sick time, and also some quarantine due to COVID, it does stress the staffing at times. Big surf is coming here on the North Shore soon, so we're definitely looking forward to hiring more lifeguards for sure.
The time is almost out, but before we let you go, I do want to go back to the issue for EMS. And we know that when Delta was hitting really hard, we had heard about EMS getting flooded with calls, people with COVID. What's your message to people in the community right now? We don't want to discourage people, obviously, from calling 911 if they need help, but what do you say to people who may be experiencing COVID symptoms and who may pick up the phone to call 911?
I never want people to hesitate to call 911. Paramedics will come to your house, they'll check your oxygen level, they'll check your temperature, they'll do vital signs, and they'll give you good advice. If you're stable and you don't need to go to the hospital, you don't have to go to the hospital just because you've called 911. We'll come out and check you out. There's no charge for that. But a lot of patients with COVID, we've gone to the house and their oxygen levels are dangerously low, and the patients didn't even realize it. And their lives were saved by getting treatment by the paramedics and transported to the hospital. It's also not too late to get a vaccine. If you still meeting people that are not vaccinated. COVID's still out there. The numbers are way down, and that's great, but it's not too late. Get vaccinated. It'll really make a difference potentially for you in the future.
Okay, well, as we close out today, any final message to the community on behalf of Ocean Safety, EMS, and the CORE program? I know you wear a lot of hats.
We have a great team. We work hard for everyone. I can only do as good as my team does, and they're great, which makes my job a lot easier. I'm proud to be affiliated with all these organizations, and they just work so hard. Ambulance running 20 calls in 24 hours is just, mind-boggling in a way. And the amount of rescues and preventative actions our lifeguards have done just as recently as just last week with this South swell. So I just really want to thank all of them for all of the work they do, and just public for being supportive.
Well, Dr. James Ireland, thank you so much for sharing so much with us about the CORE program and about both of those agencies. We really do appreciate it.
Thanks for having me. I appreciate it.
Thank you. And thank all of you for being here today. Saw some questions for folks asking where Ryan is. He's off today. He will be back with us on Monday, along with Dr. Tim Brown from the East West Center. Some of you may remember him. He has a great YouTube video of a talk he gave at the East West Center about the effects of Delta. So what's changed? What are we looking at? He looks on a global scale. So we'll be talking about other variants that could be waiting in the wings, and sort of what his view is about the trends with Delta and COVID in our community. So we're really looking forward to Dr. Tim Brown on Monday. Then on Wednesday, we have Lieutenant Governor Josh Green, who is also, of course, as we know, a doctor. And then Friday, another doctor, Dr. Libby Char. So we've got great guests next week. Very interesting this morning to hear from Dr. Jim Ireland. Loved hearing about the CORE program. As he mentioned, they did that dry run yesterday, and it sounds like this will be a very promising program to address homelessness in a new way. $3 to $5 million somewhere in there of ARPA funding going to support 2 rigs to start, and hopefully adding more as they can up those staffing levels to try to address homelessness and really get these folks the resources they need. Again, thank you so much for being here. We appreciate you. Have a great weekend. If you haven't had a chance to get vaccinated, it is not too late. As you heard Dr. Ireland say, please do engage with that and take care of yourself and each other. We'll see you right back here on Monday. Aloha.
This episode of Spotlight Hawaii was brought to you by Chaminade University.